Hi, how are you? This is Dr. Heakyung Kim. I'm pediatric rehabilitation doctor at Columbia University and Blaisdell Children's Hospital. Today, my talk is non-surgical spasticity management. So I was reviewing all kinds of spasticity management except surgical intervention. So I'd like to go to next slides. It's not moving. I have a little trouble with moving the slides. It won't move. Sorry, guys. Which one? Okay, so this is my disclosure. And today I'd like to talk about the special consideration for pediatric spasticity management and non-surgical interventions such as oral pharmacological intervention on botulinum toxin, alcohol nerve blocks, or conventional physical therapy, occupational therapy, or other type of different therapies. So when I'm a pediatric physiatrist, so when I treat patients, I always think about their growth. So they are always growing, therefore, whenever their bone gets longer, their muscle has to get longer together, but muscle is very stiff. So they're having difficulty. So therefore, they become our homework, how we can stretch their stiff muscle. And secondly, the spastic muscle is always weak due to various reasons. So we also work with the physical therapists and occupational therapists. And spastic muscle or spasticity also impact on the growing bone. So there will be abnormal rotation of the growing bone. So later, if we don't treat the spasticity in younger ages, orthopedic surgeon has to tap in and they have to do some bony surgery, osteotomies, to improve their range of motion and to help their function. So if you see this slides, he was my patient. I saw him when he was 18, almost going into 19 years old. He was referred by orthopedic surgeon for me to do botulinum toxin injection to his hamstring. But I thought, oh, he's already 19 years old. How I'm going to improve his hamstring tightness? So he was able to walk, but he was really having difficulty with walking. But if you see his hand, the right hand has least spasticity. He's kind of like a triplegic cerebral palsy. So right arm is okay, but left arm was quite spastic and both leg was spastic. So if you see the hand size, left hand couldn't grow. And then if you see his left side, the shoe lift was very high. So you can imagine his leg length discrepancy. And so for us to equalize the muscle and bone growth, we have to relax their muscles. So we give we give spastic medications such as, baclofen, and then we're going to review briefly. And then we do physical therapy. And as we discussed earlier, we will do all kinds of injections. Or surgeon, they do cutting the tendon or muscles. So in the past, when we didn't have chemical lengthening with the botulinum toxin or phenol, they used to, or they had to cut the tendon or muscles. And then nowadays we have a tool to control the diffuse spasticity with intrathecal baclofen or selective dose of rhizotomy. Sometimes we have to introduce neurosurgical interventions such as deep brain stimulation surgery. So pharmacological intervention, I know there are many medications we can talk about it, but basically, basically the Dentrium, which is directly working for the muscle. So we assume that this medication does pass the blood-brain barriers, but the problem is the liver. There's some liver damage we can expect, about 1 to 2% of patients. And baclofen is, we freely use baclofen for spastic children, but we also have to be very careful if children are quadriplegic cerebral palsy who has quite significant diffuse spasticity. They can have gastritis, and it can cause, actually, it can become pain source. So when you start the baclofen for younger children, you have to see their behavior after you start the medication to see if this medication is causing any side effect which can become a cause for the pain. And then Valium, we use a lot of diazepam for the younger children. That's the kind of a safe medication not to worry about causing the pain, but also it increases tolerance as we repeat the medication. So you have to be careful using this medication for a long period. And Catapres, or sometimes we call it clonidine. Clonidine and tizanidine is the same type of medication. It was initially invented for high blood pressure control, but later we found that these medications has a strong antispastic role, which is a spasticity management, and also it has significant pain control, and also it dries up the mouth, which means that we can control the drooling. So we are using tizanidine and clonidine for spasticity management at the same time for pain control. I know you guys have a lot of questions on medical marijuana. I don't have experience personally, but I reviewed all kinds of study which was done for the spasticity management with marijuana. There was some evidence that it does control spasticity and dystonia, and also pain in people with cerebral palsy or people with multiple sclerosis. But there's no concern on abuse or misuse, or no impairment of driving according to study. And then a local approach with the injection, the agent can be the alcohol. So I addressed a couple of alcohol here, local anesthetics such as lidocaine, but it cannot, the effect doesn't last long, so we cannot really use that one. But the alcohol, which is greater than 40%, or phenol, which is greater than 3%, they work as a local neurolytic agent. So basically, these agents are denaturing protein in the nerve, which is not going to allow to deliver the information from the nerve to the muscle. Therefore, spasticity is going to be improved. And you guys all know botulinum toxin, which I do spend most of my time to help children with spasticity. Botulinum toxin works for neuromuscular junction, which means between muscle and nerve. So we're going to talk about it a little more. So as you see, there are botulinum toxin A, B, C, D, E, F, G. Now even we have more F. So more and more botulinum toxin is coming, but A and B is commercially available because the effect lasts longer than 3 to 4 months. So the beauty of using botulinum toxin is actually we can test if this patient can improve the spasticity with the multi-level injection, which gives us idea for us to recommend the surgical intervention such as a selective dose rhizotomy. But younger children or mild spastic children, actually we can improve their function in terms of moving A to B, from crawling to sitting, sitting to walking, or we can prevent multiple orthopedic surgery in the future by preventing contractures. So I just like to introduce a couple of botulinum toxin, which are available in the market. So Botox is, everybody knows botulinum toxin is Botox, but that's not really true. Botox is an American product, which is type A. This port is from France, which is type A. And recently there was approved by FDA for the pediatric leg injections. And Xeomin is the same type A, but from Germany, and Myoblag is type B. So they have a little difference, but more so the effect lasts about 3 to 4 months, and the side effects are similar. So this is, I'm putting the needle to the injections, and also we are doing injection under the guidance according to study. guided injection is more effective than not guided injections. So you can see the needle is coming to the muscle and I'm dropping the medication. So make sure that we identify the target muscles and then we drop the medication by using the ultrasound, or if you don't have ultrasound, you can use nerve stimulator, which is close to, you go close to the neuromuscular junction to drop the medication to be effective. And as you know, medication start to work within 1 to 2 days, and then peak effect comes between 2 to 4 weeks, and then effect lasts about 3 to 4 months, and you may need to repeat the injection as needed base every 3 to 6 months. And then this patient who came to me when she was 2 years old, and she was not able to walk. She's a hemiparesis, and after I did the botulinum toxin injection to her left arm, left leg, 3 weeks after she started to walk, so a little bit of a spasticity management really improved their function. And 6 months later, just before the repeat injection, she was able to even without the injection. But as we discussed before, we need to continue more care. So we repeated the injection 6 months after the first time botulinum toxin injection to maintain her function and to prevent contractures. So you can see, this is after the third time injection. She is almost looks like a normal child who even has a hemiparesis on the left side, but due to continuum of care, she is showing nice normal gait pattern. And then rest of the therapy, conventional therapy, we recommend physical therapy for strengthening, stretching, and pool therapy for proprioceptive sensation and strengthening and range of motion. Someone who has a significant tightness of contractures, we can use casting. So you heard the serial casting. Some study shows serial casting is as effective as botulinum toxin injections, or even better than without botulinum toxin. So we usually combine after with the botulinum toxin injections or alcohol blocks, make the tight tendon a little loose so patient can tolerate the casting better. So combining therapy has been successfully helping the children. And we do not more than 5 months due to potential atrophy from the serial castings. And then you can apply the ankle foot orthosis. This is just an example of a dynamic ankle foot orthosis for children who is able to walk. We do without the assistive devices to control their ankle and knee motions. And then a couple of therapies I like to introduce, as I said, stretching, strengthening exercise. Dean Morgan is gonna more touch in depth for the strengthening, stretching exercise. And I like to discuss about evidence-based approach. And as you know, neurodevelopmental training, BOBES technique, has been doing great job, but the meta-analysis or systemic review showed there's not much evidence or when we try to improve motor learning or improve function. But I can emphasize that we need more study with the neurodevelopmental training. And as you know, habit or constrained induced therapy did show evidence that there is, if there is goal-oriented and intent therapy, there was evidence of significant improvement in hand function or locomotor function. And also treadmill training, those exercise actually didn't show the level 1 evidence, but there is an encouraging outcome has been reported. And the hippotherapy, there is still no significant evidence because all the study has been done with a small number of patients, but there is a handful study showed that there's improved co-contraction of spastic muscles, joint stability, and weight shift, postural response and control. And I know many of my patients actually do receive conductive education, but there is still, we need to have a more study to show level 1 evidence. And then I know TheraSoothe or Soothe therapy didn't show significant evidence, but some study did show that there's some improved gross motor function and functional ambulation performance after the Soothe therapy. And then I know I was curious when I go to other country, the people were doing shock wave therapy. So I was curious as I did a literature review, and there's some work for spasticity. So after the shockwave therapy, they were able to see decrease the spasticity, pain, and improve the function. So we are not really familiar with this therapy, but if you go Asia or Europe, they start to use this shockwave therapy a lot. Actually, this is very old-fashioned therapy. And then vibration. We use a vibration to improve bone density, but also we are using the vibration for the spasticity management. So whole body vibration or focal body vibration, which will also show the decreased spasticity during short period. However, there's no long-term efficacy, and further study needed at this time. And I love electrical stimulation, but also, as you see, there's no significant improvement in strength. All the physical therapy modality, using the modality, we need more and more actually research with a high number of patients. Then we can possibly show some significant evidence.